مساء الخير على الكل واهلا بكم في المؤتمر بتاع الكليه العريق بتاعتنا. واحنا السيشن بتاعتنا راديو دايجنوزس ديبارتمنت وهنتكلم على ابديتس ان راديولوجي. هنبتدي الاول بالبروفيسور دكتور امل ابراهيم and she will give a talk about the PET CT in gynecological malignancies.
Good evening, everyone. Thanks for the scientific committee for their kind invitation for this great conference. I am very glad to be with my dear Professor Dr. Amani, the head of our department, my dear colleagues Professor Aya, Professor Nurhan, and Professor Marwa. My talk will be about PET-CT in gynecological malignancies, variants, and pitfalls. In gynecological malignancies, FDG PET-CT plays an important role not only in the assessment of disease in the pre- and post-therapy setting, but also in radiation therapy planning. Now we will come for normal variants on FDG PET-CT uptake. Let's ask ourselves a question. Is every uptake in FDG in the pelvis pathological, or there are some benign or physiological conditions? Starting by the ovaries, these uptake at both ovaries are normal. They are activity physiological in both ovaries, seen as bilateral symmetrical discoid activity or FDG uptake. Another normal variant is this peripheral uptake at corpus luteum cyst, which is also considered physiological. In the uterus, there is normal physiological uptake in this pattern, which is inverted triangular shape. This is a normal physiological uptake. In postpartum period, we can also encounter physiological uptake in the uterus, but it is symmetrical, diffuse like this condition. But take care, in postmenopausal women, no endometrial FDG uptake even in endometrial hyperplasia. So, FDG uptake in postmenopausal women or abnormal FDG uptake in women with estrogen treatment warrant further investigation. What about fibroid? Fibroid is a benign condition. Can it be active or inactive on FDG? The answer is fibroid shows highly variable pattern. For example, in the first case, which is case A, we can see this intense FDG uptake. But in this case, it is low or central uptake. While in this third case, there is no evidence of FDG uptake because in this fibroid, there is cystic changes. Now for FDG activity in the tumors. It's helpful in initial staging, therapy planning, and post-therapy evaluation. Starting by initial staging or assessment, we will start by the uterus. In this condition, if we look at CT, we can see this soft tissue mass filling the uterine cervix. We can see this soft tissue thickening at the endometrium. We cannot tell whether this endometrial activity has extended to the cervix or not based on CT. But based on FDG uptake, we can see activity here and also there. So there is extension of this malignancy. This distension in the uterine cavity we cannot be sure by CT or even MRI is it pathological or it is just retained fluid by cervical obstruction. Look at FDG uptake, it is not avid, so it is just retained secretions. Uterine sarcoma has characteristic morphology on FDG, which is called hourglass appearance. The uterine segment which is involved is usually distended with retained secretion in the upper part, giving this characteristic uterine sarcoma appearance. In cancer cervix, the activity is usually concentric like this case. It can show also parametrial extension. Usually parametrial extension is associated with nodal uptake like this condition. Even vaginal tumors can also be avid by FDG, like this condition with increased activity at the right vaginal fornix. Now for the ovaries. The ovarian tumors are either benign or malignant. As a rule, benign lesions are usually cystic or unilocular, multilocular, bilateral, or unilateral, but in all, the fixed situation is that there is no activity, serous, mucinous adenoma, whatever, it is show no activity. Once there is activity, so it is a malignant condition. Other findings that suggest malignant ovarian tumor are the following. Large lesion size, more than 4 centimeters, presence of papillary projection, septal thickening more than 3 millimeters, presence of solid component, lobulated mass, nodal or peritoneal deposit. For example, this is a case of FDG. This image in FDG is called MEP image, or maximum intensity projection. It can show all the activity in whether in nodal, peritoneal, or elsewhere. In this condition, there is disseminated peritoneal deposits and nodal infiltration by the malignant ovarian mass. Another condition, by CT, it's, even if it's pathologically proven, the ovarian activity can be seen, but we cannot be definite by peritoneal or nodal lesions. If we look at FDG, these other lesions close to the iliac vessels are nodal infiltration, could be subtle by CT alone. Also, this left para-aortic tiny lymph node can be subtle to be seen by CT alone, and this ascites proved by PET-CT to be malignant ascites with intense activity. Another type of uterine tumor is teratoma. Teratoma can be benign or malignant, mature or immature. The benign is called mature teratoma, the immature is the malignant type. Sometimes by CT or MR alone, we cannot differentiate between benign or malignant. But presence of this intense activity within the soft tissue component within the teratoma suggests being a malignant rather than benign. Teratoma can also be associated with peritoneal deposits, like this condition, which also can be subtle by CT or MR. Now, there is a common finding can be seen in ovarian in the pelvis is Krokenberg tumor, which is bilateral ovarian deposits due to primary adenocarcinoma. What are the common sources of this Krokenberg tumor? Breast, stomach, colorectal, appendix, and pancreas. PET-CT can be very helpful to differentiate or to localize where is the site of primary if we are suspecting Krokenberg. For example, in this case, there are bilateral, almost symmetrical, hypodense lesions in the ovaries that show moderate activity by PET-CT. But if we look at this MEP image, this coronal MEP image, there is also increased activity within the stomach that proved to be gastric carcinoma, which is the cause of this Krokenberg tumor. Another Krokenberg tumor, but in this case, it is due to appendicular lesion. It's not seen in these images, but the typical appearance of Krokenberg is that bilateral symmetrical activity, variable activity by PET-CT within the ovarian lesions due to presence of mucinous content and cystic changes. Also, there are peritoneal deposits that also usually are subtle by CT or MR. Now, how can FDG help in post-therapy evaluation? We have to ask ourselves a question. What is the probable time to do FDG PET-CT after treatment? It depends about what was the type of treatment. If the treatment was surgical, so it's better to delay your PET-CT for 2 months. If the treatment was radiation, so it's better to delay 3 months. Why this lag or this time of delay? Because usually there are false positive findings that can be seen in the early post-treatment duration. So it's better to postpone your PET-CT to avoid this false positive finding due to inflammation after treatment. For example, in this case, that shows that had primary that was treated by surgery. Here are the urinary bladder in case 1, and here is the urinary bladder. By CT, in both cases, there is soft tissue mass posterior to the urinary bladder, here and there. By CT alone, we cannot decide if this local recurrence at the pelvis or it is post-radiation fibrosis within the bowel loops or the stump at the level of the surgical bed. If we look at case 1, this is the urinary bladder and this is the soft tissue density. By PET-CT, it shows intense activity. There is also intense activity around the surgical clip, so we can easily conclude this is a local recurrence. But in the case 2, there is soft tissue activity. There is a soft tissue density in this place. This area, posterior to the urinary bladder. By PET-CT, it is not avid. However, there is intense activity within the vagina, as we can see here. This activity is similar to that of the urinary bladder. What can be suspected from this finding is that there is no local recurrence at the pelvis, yes, but there is mostly a vesico-vaginal fistula that caused this fluid in the urinary bladder to be within the vagina, indicating vesico-vaginal fistula, which can be very subtle by CT again or MR. In this condition, there is dilatation of the ureter due to fibrosis around the urinary bladder, causing fibrosis and stricture of the lower ureter. Now, for pitfalls. By pitfalls, I mean there are some conditions that can be FDG avid in the gynecological cases, but this case, after that, proved to be a benign condition. From the very common situations are endometriosis. Endometriosis, as you all know, it is a benign, it is not a malignant condition. But by PET-CT, we can see activity within the endometriotic plaques. For example, it's also to be mentioned that CA125 can be elevated in endometriosis. Presence of elevated CA125, presence of coincident activity with FDG can raise the possibility of being a malignant lesion. But if we look at this case here, are bilateral ovarian endometriotic lesions, ovarian endometriomas. They show no activity, however, with causing ovaries. However, there is tiny, subtle endometriotic plaque within the peritoneum that is FDG avid. To summarize, endometriosis per se in the cystic component cannot be FDG avid, but endometriotic implant can be active, so don't be astonished to see an endometriotic implant with FDG activity. Another benign condition that show activity is inflammation, like this case of bilateral tubal activity within the wall of the fallopian tube. This is BID. Another case of BID with ovarian abscesses. A very common cause of BID is TB. What is confusing with malignancy is that TB can also cause TB peritonitis, and ovarian lesion also, or ovarian malignancy can be associated with peritoneal infiltration. So we have to separate between these conditions. In TB, yes, there is peritoneal deposit, there is ovarian lesion, but the condition is different. The pattern of activity within the fallopian tube wall is totally different. Last cases are appendicitis and diverticulitis. These are benign conditions, inflammatory conditions within the pelvis that can mimic ovarian malignancy, but we can follow the lesion by CT and PET-CT to be within the wall of the appendix with inflammatory condition around it, so it is acute appendicitis. And the last case is diverticulitis with activity within the wall of the colon at this level. So my take-home message is familiarity with frequently encountered benign and malignant variants and pitfalls in FDG in the female pelvis can aid in the reader in differential diagnostic consideration, and careful correlation with CTs can also help to overcome these potential pitfalls. Thank you.
Thanks, Professor Dr. Amal Ibrahim, for this very informative lecture. And I think it's crucial that interpreting PET-CT is not based only on activity. I think radiologists, an efficient radiologist that knows the different pitfalls in PET-CT is highly recommended in interpreting PET-CT, because we see many fallacies because some other who يعني في other اللي بيكتبوا PET-CT based أي activity بيبقى interpreted إن هو malignancy. The careful correlation with the clinical picture, with the anatomic variants, with the different pathologies is very important.
Yes, of course. So pitfalls must be read carefully. The pitfalls in FDG activity must be known in every system. In the head and neck, in the chest, in the pelvis. Familiarity with pitfalls is the most important to be properly investigated or read by everyone who have to write PET-CT.
Thanks, Professor Dr. Amal. The second talk is about updates in imaging of hepatic transplantation for Dr. Alaa Zahir.
Liver transplantation imaging updates presented by Alaa Zahir, lecturer of radiodiagnosis at Ain Shams University. Living donor liver transplantation is a critical alternative in liver transplantation to cadaveric ones, expanding the donor pool and enabling timely transplantation. Accurate assessment of the donor liver, including volumetric and anatomical consideration, is very essential, and it ensures an adequate future liver remnant and optimal graft volume. The vital role of preoperative imaging includes assessing the liver anatomy and exclusion based on imaging. A retrospective study revealed that 38% of living liver donors candidates were excluded based solely on imaging results. The key components of the preoperative imaging plan are 4 to 5 components. First, volumetry, vascular arterial consideration, venous anatomy consideration, biliary anatomy consideration, and hepatic steatosis. Regarding the liver volume calculation, it's critical for liver transplantation, and it should exclude the large vessels, the major fissures, and the gallbladder fossa to ensure precise measurements. Reports should include the volume of the left and the right lobes divided along the middle hepatic vein, and the caudate lobe should be reported separately from the right and the left lobe, as it might not be included in the graft. Hepatic anatomical consideration. Accurate preoperative assessment is key to preventing graft ischemia. According to Michel classification, it defines 10 hepatic arterial variants, and they are key to surgical planning. The most common anomaly in hepatic arterial anatomy, according to Michel classification, is type 5, in which the right branch originates from the celiac trunk, replaced right hepatic, and the accessory left hepatic artery from the left gastric artery. The site of bifurcation of the right and the left hepatic arteries are highly relevant in the surgical planning, because if the bifurcation of the proper hepatic artery is intrahepatic or extrahepatic, the arteries might encase the common hepatic or the common bile duct, and this scenario can further complicate the surgical procedure. Regarding the portal venous anatomy, classification schemes such as Nakamura and Chang were crucial for understanding the portal venous anatomy. The most common orientation is the normal orientation in the form of the main portal vein bifurcating at the hepatic hilum into the right and the left portal veins, and then the right portal vein bifurcates into anterior and posterior branches, while the left portal vein divides into 3 branches, one for each segment of the left lobe. Rare variants, including intraparenchymal branching of the right anterior portal vein from the left portal vein or an undivided main portal vein, are contraindications to right lobe donations, and they might also complicate the left lobe donations. Hepatic venous anatomy. The hepatic venous anatomy, while variable, commonly consists of 3 main veins: the right, the middle, and the left hepatic veins, and these veins play a crucial role in draining blood from the different liver segments. Variations in the middle hepatic vein are particularly significant from the surgical perspective, as the hepatectomy plane in liver donors typically lies within 1 centimeter of the middle hepatic veins, making its anatomy crucial. And so preoperative assessment for careful evaluation of the middle hepatic vein is essential to avoid injury during the liver resection. And surgical planning, understanding the variation helps in the planning of the hepatectomy to preserve the adequate venous drainage. And postoperative, maintaining proper middle hepatic vein drainage is crucial for preventing venous congestion. Regarding the biliary anatomy, MRI with MRCP is the current standard for the non-invasive evaluation of the biliary anatomy, and conventional anatomy is seen in approximately 55% of individuals, while the variant anatomy most affect the right biliary system, requiring careful consideration during the surgical planning. Common biliary variants, including the right posterior hepatic duct draining into the left hepatic duct, might need more than one biliary anastomosis, especially for the right liver donation, and increase the risk of biliary complications such as biliary leak and anastomotic stricture, requiring meticulous surgical technique. Also, liver parenchymal imaging, hepatic steatosis, poses risk for both the donor and the recipient in the living donor liver transplantation, and so accurate detection and quantification of steatosis are essential for donor selection and also recipient management. The CT is 88 to 95% sensitive and 99 specific, where detection of steatosis, where the liver attenuation is 10 Hausenfeld lower than the spleen. Also, MRI could be used for quantitative and qualitative assessment of steatosis, where the loss of signal intensity on the out of phase compared with in-phase images indicates fatty liver, and a quantitative evaluation of the fatty liver can be achieved with the multi-echo PDFF technique. And so our structured report should include detection of clinically significant steatosis, characterization of the liver lesions, volumetric results, and description of vascular and biliary anatomy. This ensures comprehensive communication of the imaging findings. AI innovations in liver transplantation. Since liver transplantation is a complex procedure involving numerous preoperative, intraoperative, and postoperative treatment phases, hence application of AI can be seen during the 3 stages of liver transplantation. Regarding the pre-transplantation stage, it could be included in patient selection and risk stratification, because although MELD score predicts short-term mortality risk with high scores indicating an urgent need for transplantation, but it still contains certain limitations. Notably, it doesn't consider clinical complications related to cirrhosis and portal hypertension. And that's why AI has been used for assessing the severity of the liver disease and enabling the early identification of the patients in need of urgent transplantation. And so various AI-based algorithms have been deployed with results equal to or even outperforming the MELD score system. Because in addition of the MELD score system, they included clinical parameters including ascites and hepatic encephalopathy. Regarding the transplantation operation, AI could be included in surgical planning and intraoperative assistance, and also in graft evaluation. In surgical planning and intraoperative assistance, an algorithm-assisted CT volumetry method was introduced for estimating the graft weight, and it proved to be less time-consuming than the conventional manual technique, with 70% of the tested grafts not requiring additional corrections, and the remaining 30 requiring only minor alterations. Regarding the graft evaluation, liver grafts often exhibit significant steatosis, a condition strongly associated with early allograft dysfunction, and that's why it's important to accurately detect and quantify steatosis in the pre-implantation liver graft biopsies. However, this could be challenging and invasive, and that's why an objective computer vision artificial intelligence platform developed a score for donor liver steatosis, providing quantitative and calibrated results. Our last step is the post-transplantation stage, where after liver transplantation is critical to determine the function of the liver graft and to detect any complication. And that's why, since it's a complex procedure involving patients who often present with multiple comorbidities, it might lead to various post-operative complications. such as vascular abnormalities, biliary strictures, infections, rejection, and recurrence of malignancy, diabetes, and cardiovascular and renal complications. That's why AI have been used in detection of the following complications, like the infection and cardiovascular problems, and also graft versus host disease. Infections are the most prevalent complication following liver transplantation, and so the types of infection that might develop depends on the time elapsed since the transplantation procedure, the type of immunosuppressive therapy, and any pre-existing infections. Therefore, the role of algorithm includes the prediction of occurrence of infection as well as the severity of the most common infections in the liver transplantation. Also, cardiovascular complications are among the greatest risk in every major operation. And so an algorithm using the following data developed to detect the high probability of developing a major cardiovascular event, including pre-existing cardiovascular conditions, pre-operative hemodynamically instability, and long-term metabolic effects of immunosuppressive therapy. To summarize, liver transplantation is a complex procedure requiring proper pre-operative assessment. Key components to pre-operative imaging plans include volumetry, anatomical considerations, and pathologies like steatosis. Advancement in AI use for liver transplantation includes the development of a personalized patient care, organ allocation algorithms, and predictive models for graft function evaluation. Thank you.
Thank you, Dr. Ala, so much for this nice and informative lecture, and thank you for highlighting the role of AI in liver transplantation. Maybe we can, in the coming period, start exploring this, and maybe a candidate can start working on one of these algorithms.
Hopefully.
Oh, yeah, thank you. Thank you so much. Our next talk is also AI in pediatric imaging, how can it help, by Dr. Marwa Mohammed. Thank you so much, Dr. Marwa.
Thank you, Dr. A. Our talk is about AI in pediatrics, how can it help? Artificial intelligence, AI, has received widespread and growing interest in healthcare as a method to save time, cost, and improve efficiencies. We have to know that children are not young adults. There are intrinsically challenging aspects surrounding the practice of pediatric radiology. If long duration of imaging, it will need sedation or general anesthesia. Consideration for radiation exposure if ionizing radiation is being used. Need to obtain images of optimum quality. So, AI solutions could and should be used to enhance the workflow of pediatric radiology. So it can use in many aspects. First of all, clinical decision support, CDS. Clinical decision support, implementing an AI-enhanced CDS tool could allow for rapid synthesis of all patient information held within electronic health records, matched against national referral guidelines, and provide clinicians the most appropriate next course of action. Second, image acquisition. Decrease imaging acquisition time, decrease radiation dose, improve the image quality, and decrease the IV contrast dose. All of these are needed. First of all, MRI scanning and image quality. We need to decrease the motion artifact by training a neural network to learn relationships between zero-field K-space and fully sampled K-space for particular study type, then allowing for interpolation of missing data in future unseen studies. CT image quality and radiation reduction, reconstructing high-quality images from reduced amounts of raw data by teaching an AI model the typical appearance of low-dose CT artifacts and then subtracting these from other low-dose CT images could enhance image quality without increasing radiation dose. IV contrast usage. Deep learning techniques have been reported to help produce high-quality post-contrast MRI images in cases where only a fraction of the usual dose of gadolinium-based contrast agent has been administered, as seen there in this photo. learned to denoise contrast-enhanced signals to predict full-dose contrast-enhanced MRI images. Quantification. As volume measurement of pneumothorax, volume of CSF and brain tissue in hydrocephalus, measurements of leg lengths on lip radiographs, and last but not least, scoliosis angles from spine radiographs. Volume measurement of pneumothorax. The amount of pneumothorax is calculated as the radiolucent area between the lung parenchyma and the chest wall on simple chest images, and as the radiolucent volume within the pleural cavity on CT chest, as shown in these images. Volume of CSF and brain tissue in hydrocephalus. AI diagnosis model can diagnose hydrocephalus by analyzing the factors of the shape and volume of ventricle, as well as Ivan index and age. Measurements of leg lengths on limb radiographs. These images showed examples of good and bad segmentation, and B diagram showed calculation of pediatric leg length based on segmentation mask obtained by DL algorithm. Measurement of scoliosis angles from spine radiographs. Automatic approach called minimum bounding rectangle MBR method to obtain the upper and lower border of the vertebra to measure Cope's angle, and also segmentation of whole spine. Predictive modeling. AI techniques have been commonly used to prognosticate clinical outcome and determine treatment regimen. AI models help in detection size, location, morphology, and the presence of edema in brain tumors, and accordingly expecting whether it's low or high grade. Image interpretation. As bone age, fractures, and in-chest X-ray. First, bone age. AI systems yield results comparable to traditional manual bone age assessment, offering the merits of objectivity, efficiency, and time saving. Bone fractures. AI is an effective tool for fracture detection that has potential to aid clinicians in busy emergency departments. Chest X-ray, it can show it's normal or showing opacity or technological opacity or pulmonary edema, bronchial thickening, bronchitis, bronchiolitis, bronchopneumonia, other diseases, or pneumonia. Segmentation. Segmentation involves the identification, localization, and isolation of predefined structures within the medical images to identify tumors, organs, or other structures for image processing and interpretation. Few PET-CT images shown in this image show automated multi-organ segmentation using publicly available UNet deep learning model, including segmentation of brain in yellow color, bones in pink color, lungs in red, trachea, heart in blue, aorta in green, liver in orange, and spleen in purple. The last but not least is reporting. Ensure images most likely to have a significant abnormalities are flagged up on the reporting work list and reported by the radiologist first. So the image is go to PACS and AI, then a platform to data report, including data provided by AI, the structured report populated with AI findings to radiologists, cause its validation and adjustment, going to PACS and then clinical refers. To summarize, the current climate represents an opportunity for early adopters to better determine how AI solutions could and should be used to enhance the workflow of pediatric radiology, potentially providing a more individualized patient and referral-centered approach through patient presentation and referrals, through clinical decision support, examination and booking by availability of specialist imaging lists, image acquisition by reduction in scanning time, radiation dose, improved image quality through artifact reduction, post-processing as artifact removal and automated labeling, quantitative analysis in form of segmentation of organs, tumor lesions, lesion volume, joint angle calculations, bone age measurement, signal intensity of pathologies, interpretation in detection of abnormalities and the classification of abnormalities, and reporting by hanging protocols and automated documentation and multimedia reporting. The integration of AI technology facilitates informed clinical decision-making processes, thereby promising advancements such as quicker and more accurate diagnosis, personalized treatment plans, and reduced healthcare costs. Thank you.
Thank you, Dr. Marwa, about your interesting lecture about AI. It was concise but very updated. Our lecture now is about dual-free technetium 99 pertechnetate versus STEMIBI scan for detection of suspected thyroid nodules by Dr. Toa Omar.
Hi, مساء الخير. We'll have a talk on role of scintigraphy and PET-CT imaging in management of cold thyroid nodules. Topic prepared by Dr. Minatullah Hatem, Professor of Radiodiagnosis at Ain Shams University Hospitals, to be presented by me, Toa Omar, Assistant Lecturer of Radiodiagnosis at Ain Shams University. So let's get to it. The most concerning thing about cold thyroid nodules is increased suspicion of malignancy up to 5%. So early and accurate diagnosis is crucial for directing treatment plans. Initial evaluation includes measurement of TSH levels, performing ultrasound, thyroid scan, and fine needle aspiration biopsy. Starting with the most gold standard tool in the assessment, fine needle aspiration biopsy. It's safe and minimally invasive method, yet being operator dependent gives a high potential of non-diagnostic results up to 32%, requiring a rebiopsy. Ultrasound identifies thyroid nodules, as you all know, by suspicious characters like marked hypoechogenicity, irregular margins, and microcalcifications, but is not recommended alone. However, although real-time elastography has been recently reported to increase the sensitivity of ultrasound, it still gives suboptimal accuracy in diagnosis of these nodules. On the contrary, thyroid MIPI scan has been recently used on a wide scale as an investigation for these nodules. The radioisotope accumulates in mitochondria-rich cells as hyperplastic malignant tumors and parathyroid adenomas. Negative MIPI study is defined as a matched study where the nodule, as shown here, show no uptake on either free technetium scan or technetium MIPI scan, while positive study is considered when there is no uptake on free technetium study, but hot uptake on technetium MIPI scan. Those nodules are associated with high risk of malignancy, so increase the need of surgical removal. Unlike those with negative uptake, show marked decrease in this risk. So, MIPI scan has a high negative predictive value. It can usefully exclude malignancy and can be used as a second-line investigation after fine needle aspiration to reduce the unnecessary thyroidectomies. Here, we will go on an overview of some studies done to compare between MIPI scan and other imaging modalities in diagnosis of these nodules, with correlation of results by fine needle aspiration and histopathological correlation. First study was designed to compare technetium MIPI scan with FDG PET-CT and then correlating the results with histopathological findings. For the PET-CT, we calculate SUV max. For MIPI scan, we calculate nodule over background activity ratio at both early and late images, and positive MIPI scan is considered when nodule over background activity is more than 1. As demonstrated here, there was focal increased activity on PET images at a left thyroid loop, with increased activity as well on early and late MIPI studies, with nodule to background activity of 1.3 and 1.5 in early and late images respectively. We have positive PET scan and positive MIPI scan. Histopathological correlation confirmed papillary carcinoma. Another case where there was as well focal increased activity on PET-CT images with SUV max of 6, positive activity in both early and late MIBI images with nodule to background uptake of 1.8 and 2.1 at early and late images respectively. So we can say we have a positive PET scan and a strongly positive MIBI scan. However, the striking thing is that histopathological correlation of this nodule revealed a benign follicular adenoma. So this study suggested that FDG is not superior to MIBI scan in differentiating malignant nodules from benign ones, as both can give false positive results. MIBI scan should be preferred used as preferred imaging modality for preoperative management in patients candidate for surgery. Also, the study put an eye on the dilemma of follicular lesions. Follicular lesions, neither MIBI scan or PET scan were able to discriminate benign follicular adenoma from malignant transitional carcinoma. So follicular lesions require definitive histopathological correlation. Another study compared the technetium MIBI scintigraphy with multiparametric neck ultrasound results and FDG results with correlation by histopathology. As we have mentioned, SUV max is calculated for beta studies, nodule to over background activity ratios are calculated for MIBI scans, and as we all know, multiparametric ultrasound is considered positive when the nodule shows at least 3 of these characteristics. Being solid, hypoechoic, irregular margin with microcalcifications or intraregional blood flow, or increased nodule stiffness or on elastography. Here, we have an ultrasound of a right thyroid lobe nodule. The nodule was hypoechoic, solid nodule with irregular margin, no vascularity detected on color Doppler, and showing increased stiffness on real-time elastography. I mean, it fulfills the criteria being suspicious by multiparametric ultrasound. PET-CT as well shows focal increased activity, while MIBI scan was negative. Histopathological correlation showed papillary carcinoma. Another case of isoechoic solid nodule with a well-defined margin. As you can see, there is no suspicious criteria. Unless it shows increased stiffness on real-time elastography. So by multiparametric ultrasound, we can say it's negative study. And MIBI scan showed also negative uptake. However, FDG PET-CT shows focal increased uptake. Histopathological correlation showed a small subcapsular follicular carcinoma, a papillary carcinoma, sorry. So the study concluded that FDG PET scan is more standardized than MIBI scan with high negative predictive value. We mean that positive nodules on FDG scan deserve lobectomy and histopathological correlation, while negative ones most likely to be benign. To another imaging modality, SPECT-CT radioactive iodine scan, it's indicated after thyroidectomy to detect remnant or recurrent lesions. Here, we have a whole body iodine scan for a patient after total thyroidectomy of multifocal papillary carcinoma. As we see here on a planar whole body iodine, there is increased activity at posterior chest images, turned to show multifocal iodine avidity on SPECT-CT consistent with pulmonary mets. However, whole body iodine gives unusual benign activity distributions like in lacrimal glands, esophageal secretions, breast, skin contamination, and sometimes radioactive iodine accumulates in retention cysts. As in this case, of also patient with multicenteric papillary carcinoma underwent total thyroidectomy and received his first treatment, his first radioiodine therapy session. Planar CT showed 3 distinct focal activities. Anatomical localization of these lesions show the superior lesion here is benign lesion, benign uptake in the nasolacrimal duct. The second one shows also benign uptake at the thyroglossal cyst. The last one was at the anatomical site of the thyroidectomy bed, tended to be residual thyroid tissue. Another one, here there is two intense foci. The one on the left is the anatomical site related to surgical clips and is diagnosed as the residual thyroid tissue. The one on the right showed nodal mets. This one, with intense activity in the middle of the neck, with anatomical localization of it, it was a paratracheal lymph node, which means it's also a nodal mets. So, value of SPECT-CT, and that it's crucial in redirecting treatment plan, whether to give or withhold radioiodine therapy, guiding the extent of surgery, and indicates the need of alternative imaging modalities. Drawbacks include increased radiation exposure with limited spatial resolution that means micrometastases and small lesions may be missed. But the major drawback of SPECT-CT is that there is approximately up to 30% of dedifferentiated thyroid carcinoma may be missed by SPECT-CT. Why? Because the fact that dedifferentiated tumors loses their iodine avidity. However, it gains FDG avidity, and what called flip-flop phenomena. So, dedifferentiated thyroid carcinoma couldn't be detected by iodine scan. However, FDG scan could detect it. Here, we have a whole body scan for a 50-year-old patient after his first radiotherapy sessions, showing clear lung fields with no increased activity. CT showed pulmonary nodules, the largest was 1 centimeter. This nodule showed no uptake on a SPECT-CT, however showed intense, strong uptake on FDG. This is the flip-flop phenomenon. This is a dedifferentiated tumor. In these patients, the recurrent tumor couldn't be detected by whole body iodine, and as well it is also shouldn't be treated by it. Home messages. MIPI scan has shown to have negative predictive value for excluding malignancies. It can be used as second-line investigation after fine needle aspiration biopsy. FDG positive pattern is significantly associated with cancer, while negative one predicts benign lesions. Association of FDG multiparametric ultrasound is more specific than FDG alone. SPECT-CT improves the interpretation of classic whole body iodine scan, and as it allows accurate anatomic localizations. As well, it impacts the management in significant number of patients. FDG scan is the most useful tool in patients with serum thyroglobulin above 10 nanogram per millimeter with negative whole body scan and dedifferentiated thyroid cancers. Thank you.
Thank you, Dr. Toa, for your presentation. Thank you very much. We will open now for any questions to any one of the speakers. No one has questions for anyone? Yes, please.
تسأل الدكتورة مروة عن ال AI. مروة مش موجود؟ طب الأستاذ دكتورة، هو ال AI بس أنا هسأل الفالسز بتاعته، يعني إحنا هنعتمد عليه تماماً ولا avoid الفالسز أو نخلي بالنا من أي
دكتورة مروة موجودة. حضرتك تحب تسألها الأول ولا ال AI؟
بسأل عامة عشان الأستاذ دكتورة برضو اتكلمت عن ال AI قبل كده. فهل يعني ال AI
اتفضلي يا دكتورة مروة عشان في سؤال ليك.
أنا بسأل حضرتك. أنا محمد غفار، أستاذ طب المنوفية. بقول لحضرتك ال AI عاوزين افويد الفالسز بتاعته او الديبند اون عشان ما يعملناش مسليدنج بعد كده. هل بنعمل بريكوشنز معينه او حاجه عشان
هو اصلا فكرته الديب ليرنينج، يعني في ديب ليرنينج الاول، يعني محتاجه انها ندخل داتا كتير جدا 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 جدا. ده بحد لازم يكون اكسبرت راديولوجيست اصلا،
حتى لو دخلنا الداتا كتير، هل ما عندناش اي فالسز منه
داتا
إن هو
بريسايزلي.
يعني يعمل لنا مسليدنج في حاجه؟
ما هو يعني احنا بنعمل ريفيجن، يعني الاول اول حاجه بتبقى في ريفيجن، يعني اول حاجه ديب ليرنينج، يعني احنا كميه داتا رهيبه، يعني مثلا احنا محتاجين مثلا نشخص تيست اكس راي، الالجوريثم بيبقى فكرته ايه؟ ان انا ادخل مثلا 10000 شيست اكس راي انا متاكده ان الراديولوجيست بيك اكسبرت شافها، تدخل جوه مثلا ده نورمال كتير كتير كتير، هو بيتعرف على شكل مثلا شكل نيموثوركس، هو بيبقى عارف شكلها بناء على اللي انا قايله له اصلا.
ايوه.
فهو يسرع المهام بتاعتي، وستيل وي نيد ريفيجن طبعا للاوتكم برضو، يعني انا لو شفت الايمجز اللي هو قال انها كذا عادي بس اسرع، يعني انا فكرتي ان هو لو قال لي ان دول كلهم عندهم نيموثوركس انا هقول تمام تمام تمام، اسرع بكتير ما كنا بعمل كل حاجه لوحدي.
يعني هندبند اون كام برسنت يعني على الاي اي؟
هو مفيش حاجه 100% كده كده.
أنا بس
شكرا.
أنا ممكن بس برضو أرد على السؤال ده، يعني مثلا احنا في هو ال AI لغاية up till now can't replace ال human، هو يعني أداة مساعدة للإنسان، بس لغاية دلوقتي هو can't replace ال human، هو بيساعد ال young radiologist إن هو يبقى as expert radiologist، بس هو ليه fallacies وفي ليه فالسز كتيره زي ما الدكتوره مروه قالت، هو ديبند على الديب ليرنينج، كل ما يبقى الديب ليرنينج ده على مودلز وارقام كبيره كل ما الاكيورسي تزيد، but up till now يعني هو ما يقدرش تو ريبليس الهيومن لانه له فالسز وسمتايمز ان اكسبليند، يعني ساعات في البريست مثلا بيبقى في ماسز كبيره جدا وهو ما شافهاش، يمكن لانه شافها او انتربريتد على انها دنس جلاندولار دنسيتي مثلا، فهو يعني هو اداه مساعده بيسرع الوقت، بيحسن من اداء اليونج راديولوجيست، but up till now it can't replace the human being.
والريزلت بتاعته ما اقدرش اعتمد عليها فرانكلي، لازم زي ما حضرتك بتقولي ان احنا نقرا، يعني عادي هو مثلا قايل حاجه معينه هو هيساعدني حتى كديفرنشال دايجنوستس، هو ممكن يساعد بس في الاخر انا برضو ببص تمام ماشيه ناحيه كذا اكتر، يعني هو بيساعد فعلا.
شكرا دكتوره مروه.
في اسئله ثانيه؟ اتفضلي.
My question is for Professor Dr. Amal. About PET-CT and FDG avidity in general, there is a different numerical value for SUV max. Like some papers have cutoff values for different malignancies, and others they say that it's variable. So, by your experience, do you think that a number for FUV max is like a dependent? We can say like this is like more sarcoma or carcinoma, or just like any avidity is in general.
Thank you, Dr. Maureen, for your question. Actually, starting by the hepatic reference, if the lesion is higher than the hepatic reference 2 to 3 times, we cannot tell it is inflammatory or neoplastic. Sometimes the neoplasm is low grade, so it can show low FDG activity. Even inflammation sometimes can reach, for example, SUV 5 or 6. Malignancy can be 4, for example, in lymphoma. So we cannot have a cutoff point for this, but the morphology together with association can help in this differentiation. But no cutoff point as long as you are 2 to 3 times above the average hepatic reference. This information is for whole body screening, not only in gynecology. No. Thank you.
Thank you for your question. Any other questions? Okay, I would like to thank all the speakers. Sorry. تفضل
حضرتك الاندومتريوزس، هل الاندوسكوبي يعني البيت سي تي هيغنينا على الاندوسكوبي؟
Endometriosis, the usual situation is that FDG, it cannot be active in FDG except for the active nodules, soft tissue nodules. But the cystic component in endometriosis, ovarian endometrioma, or tubus or hematosalpinx, is not avid by FDG. So it cannot replace laparoscopy by any way. No, cannot replace.
Okay, thank you very much to all the speakers, and I hope you all had a scientific learning that sounds good. Thank you very much. Thank you.